All right, now we're back. Okay, so we're going to record the lecture. So, again, when we're talking about rhythms that originate in the AV junction or the AV node, the thing I want to make sure that we start off with the very first part of the lecture and we clear up. There's a big difference between junctional rhythms. Okay, we typically call them I like to call them junctional rhythms because it differentiates them from AV blocks. Okay, now remember for your AV blocks, first degree, second degree, type 1 and 2, and third degree block, where do those rhythms originate? No.
In the essay or the criminal.
Okay, good. So it could be the SA node, yes, or it could be somewhere in the atria. We're not entirely sure, okay, but we'll just simply say it's somewhere in the atria, okay? So AV blocks originate in the atria. Now, again, the intrinsic pacing rate of the atria is what? 60 to 100. Now we're coming down to the junction, the AV junction, the AV node, or you just may call them junctional. When, under normal circumstances, what is the intrinsic pacing rate of the junction? 40 to 60. Now, that's going to be one of the key things that you're going to look at when you're going through this 5-step process of identifying these particular rhythms, okay? And that's going to be really important. But now, don't hold on to that real tightly because we're going to talk about some rhythms that are faster than 60 and yet they're still originating in the junction, okay? In the junction. Now, as far as what we're looking at here, so keep in mind that the components of the electrical system is the impulse would normally start up in the SA node, travel down through the intranodal pathways, coming, and as it does that, now it depolarizes the left and the right atria, and they contract. They empty their blood down into the ventricles. All right. Now, it comes on down to the AV node. It gets held up there, and then it gets sent down through the bundle of His, down into the left and right bundle branch, into the Purkinje fibers. Now, when we are dealing with rhythms that are rising from the junction or the AV node, what would be, in your opinion, what would be some causes of that? Why would we see the junction becoming the dominant pacemaker of the heart? We could potentially have tissue death in the atria. Good faith. What else? We could potentially have a chemical imbalance. In particular, what chemicals are we first thinking about when we think about the heart? Sodium and potassium. Very good. Very good. Okay, what else? Because remember, when you're thinking of the causes of this, you need to also be thinking of, can I fix them or can I at least help them?
With severely hypoxic.
So we can have hypoxia. So death of tissue, not much that we're going to be able to do as far as those particular patients go. Electrolyte imbalances, depending upon where we work, there may be some things that we can do to fix that, okay? Hypoxia, we can work on that. We can work on that, okay? So that's the thing I want you to remember is when you're looking at these rhythms, is number one, where are they coming from? Number two, is it possible that they can kill my patient? And number three, is it something that I can work on to fix? Now, junctional rhythms are not normally considered life-threatening, except in the fact that sometimes junctional rhythms are not nearly as effective of moving blood out of the heart because of the way that it occurs, okay? The other thing is junctional rhythms can be slow. If they're down on the slower end of 40 and your patient's a big person and they're needing that heart rate to be up higher, now we're beginning to run into some issues of where the junctional rhythms can be a big problem. Now, basically what we're looking at in here, let me get on beyond this, is This is the area of tissue in which the impulse is going to begin to arise. Now, let's think about normal progression of the impulse and what you see on the EKG. When we have, come here, when we have an impulse that arises up here in the atria, what is the normal direction for that impulse to go?
Positive deflection.
Okay, that it results in a positive deflection as a result of what? Going down towards what? Going towards lead 2, okay? Going down towards the positive electrode that is down here. So heart's up in here, impulse starts here, its generalized direction is this way, all right? Because it's headed towards the positive lead. You're exactly right, Skylar. Now we get that positive deflection coming up within the EKG. But now here's the thing you got to remember. If our impulse starts right in here, what do you surmise would be some things that you might see differently on your EKG? Say it again. First of all, you may not see a P wave. Okay, very good. Now, it doesn't mean that there's not a P wave in there, but it's probably swallowed up by your QRS. Good. Braden. Okay. Anybody else? What else might you see?
Could we expect the electrical signal to go the opposite direction?
Well, if it starts here, and remember that whole excitability property of your heart says that when we get an impulse, it gets shared. Then basically what's going to happen is that it's going to have to go back up this way. How's that going to be reflected on your normal lead 2? Yeah, what do we call that? We have a negative deflection or an inverted P wave.
Down.
Yep, a down loop. Okay. So we've seen 2 things here. There's one more. Okay. So we can have no visible P wave. We can have an inverted P wave, or we could potentially see a P wave after the QRS. After the QRS. All right. That's going to be really important for you to remember. Now, again, here's the key to remember, as you'll see as we go through here. Make sure, and I think one of the reasons why the vast majority of this class did so well is you guys have become really, really expert in that 5-step process. What other rhythm do we look at that doesn't have any P waves that we've already covered?
AFib.
AFib. What's one of the hallmarks of AFib? No P wave and
Irregular.
Grossly irregular. Your your junctional rhythms will probably be regular. Okay, so now we're picking up here something. Okay, no P wave, but my QRSs are all over the place. I'm beginning to think that may be AFib. But if I look at the next one, it's no P wave, but boy, look how regular those QRSs are. Now I'm thinking maybe I've got a junctional rhythm that's going on here for this particular patient. Okay. Now let me ask you another question here, because you guys are obviously very smart people. If we have a retrograde P wave or a retrograde impulse that starts here and goes back this way, what impact is that going to have on the contractility of the atria?
Aren't they going to be contracting almost at the same time?
They would just about contract at the same time anyway. Think your normal conduction pathway and now compare it to starting at the junction and going backwards.
Your ventricles are going to fire.
Maybe. Well, it could be, because that may be why we would see that P wave after the QRS. But I'm talking about the mechanical action of the atria.
Well, probably not. It's not going to be doing as good as it was.
Why?
Cardiac output.
Yeah, you're right. Why?
It's not squeezing what it's supposed to be waiting.
Yeah.
It doesn't
Why?
Have, it doesn't have the full electrical conduction to allow that contraction.
Yeah, why? I can do this all day. It's Monday.
4-year-old.
Yes. I've been compared to a 4-year-old. Thank you. Keep in mind that the impulse is going backwards. Have you ever tried to do something that you've done your entire life except to repeat it in a backwards direction? It's not efficient. It doesn't work as well, which means that as far as from the contractile force of the atria is probably going to be impaired. Which means what? For our cardiac output, ladies and gentlemen, yeah, it's a good possibility of going to go down. Skylar, that could potentially be one of the reasons why our patient is hypoxic. All right. Now, that's the top half of the heart that we've covered. What impact, if our impulse originates right here and it comes down this way, what impact is that going to have on the ventricles? Dylan?
With less blood flow.
Potentially, yeah, you're exactly right. It is potential for the, well, again, because of the speed of the conduction, and again, remember, it's coming from the junction. The junction is part of the conduction system, so it's right there on that track. So, Abe, what you said about the ventricles firing first is a distinct possibility. And again, I come back to this is why we may see the QRS and then the P wave afterwards. But it's not going to have any impact on our ventricles. Why? I just told you the reason. Why? Tacey, why? Perfect. Yeah, it's still following the normal electrical pathway, even though it's starting down at the junction. Okay, so it's at the junction, going through the bundle of His, left and right bundle branch, and then up through the Purkinje fibers. Okay, instead, now what's happening is it's having to go backwards in a less efficient manner up in the atria. Okay, so again, then let me ask you one more question about this. If the ventricles are functioning correctly, why might our cardiac output be reduced in a slow junctional rhythm?
Because they have a decreased freeload.
As a result of what? Yeah, so you can see everything is interconnected together. There's an old song that says that the ankle bone's connected to the shin bone's connected to the knee bone, and the knee bone's connected to the femur or the thigh bone. And the heart is the same way. So everything is interconnected so that when something doesn't work, we're going to see some type of misoperation, some type of failure. Doesn't always necessarily mean that it's going to be critical or life-threatening for a patient. Because remember, I just told you that junctional rhythms, especially if they're up on the higher end, are not going to be life-threatening for a patient. But it does serve for us to take notice. Now, again, as we're looking at here, we've talked about the review of the conduction system of the heart. We've talked about the intrinsic pacing rate of the heart. And when we talk about the Purkinje network or the Purkinje system, that's the same thing. If you tell me the ventricles, that's the exact same thing. Okay. So again, as we go down the heart, the slower the heart rate, and that's going to be really, really important. Now, what we're looking at here is the top impulse that we've got going on right here. This is our normal P wave. You can see it's normal, it's upright, it's rounded. Now, ladies and gentlemen, what can you tell me about our P waves down here in the lower EKG rhythm? Braden. Yeah, so the electrical current is going up where? Up into the atria. Very, very good. Okay. And that results in two big changes on this EKG that we're looking at. What are they? Dylan?
Well, one's the P wave is inverted.
That's one thing.
I know that you said they're regular.
They are regular. Yeah, Braden. No, the QRS will be normal. Now remember, a normal, because if you look at this QRS, does it look like it's a normal width to you? I hope you nod your head yes, because it is perfectly normal. Normal is anything less than 3 small boxes, which is 0.12 seconds or 120 milliseconds. Say it again. Not longer. Mm, it potentially could, but now we know that the P wave is not embedded in the T wave because, again, you could potentially see if it occurs afterwards of it being a part of that T wave. But we know it's not there because we've got a pretty clear indication of these inverted P waves. Look at this P wave. What do you notice? Okay, can't get out of it. Okay, there we go. What do you notice about the PR interval?
It's upside down.
No, the P wave is upside down. The PR interval is not. It's really short. Why is it really short?
Because there's no traveling required at all. It's already there.
Remember, the PR interval, ladies and gentlemen, measures what?
The space between the atrial depolarization and the ventricle depolarization.
Mm-hmm. So again, if our heart, let's go back here.
So if it's normally waiting for that initial impulse and the impulse is already there, there's no time.
Yeah. So if our impulse is occurring, let me back up. If our impulse occurs up in here, we've got to have that brief fraction of a second for it to go over here and then to travel down into here to get hung up at the AV node. Okay. Now, if the impulse originates at the AV node, basically what you're going to do is you're going to have a firing with an inverted P wave and then your QRS. So your PR interval is normally going to be less than 0.12 seconds. Another key finding as far as when you're doing that 5-step process of going through and identifying what you've got for this particular rhythm. Now, let me stop there and take a breath, take a drink of my tea. Is that clear? Because if it's not clear, we got to talk about it because that's two of the things that's going to help you to identify this. Anybody have questions on it? Yes, Bill.
So, if you said it fires back up the atria, so does it come back down from there?
Mm-mm. No. So once it fires here, this gets the impulse and it fires, and then the cell next to it gets it and it fires. So it gets. Think of like throwing a rock into a pond with that ripple that goes out from the center. That's the exact same thing that happens. So when that impulse fires at the AV node, it's sending it down into the ventricles. At the same time, it's sending it back up into the atria. So they don't fire and then refire down here. That's a great question, by the way. Anybody else? Hey. Okay, let's do this. Oh no. Let's make this puppy a little bit bigger. Now, as we're looking at this, again, remember, and I can only go to one side when I enlarge. Right here is our AV junction. Okay? So when it fires, remember it's sending the impulse down and it's sending the impulse back up. The next stop, immediately after leaving the AV node, is the ventricles. So it gets on that track, is what we had said a while ago. Tacey had said a while ago. It gets on that track and the ventricles will depolarize. So again, it's right there next to the door of the ventricles. So for example, if I said, okay, let's have a race to see who can get out of this room the quickest. I'm going to that door, and Abe, you're going to that door. You're younger, you're lighter, and you're smarter than me, but I can guarantee you from right there to right here, from right here to right there, and you going right there, I'm going to beat you. Okay? That's the exact same thing that happens here. It fires and then our QRS occurs because it's closer to the door. Does that help? Anybody else? These are good questions. Okay. Let's look at some rhythms. All right. Remember we talked about premature atrial contraction, PAC. What did I tell you you needed to remember about PACs? Yeah, some of y'all forgot on your exam. You told me about the PACs. That's why you'll feel lucky that you got like a 0.5 on your score. You forgot to tell me the underlying rhythm. Bunch of you gave me really good answers as far as the conduction ratio for the two A flutter rhythms that we had. Almost nobody gave me the conduction ratio for the secondary blocks, though. So kind of keep that in mind for the future. With a premature junctional contraction, we're also going to be looking at the underlying rhythm. Okay, so basically, what we're looking at here is just like when we talked about premature atrial contraction. We're talking about the same thing with a premature junctional contraction, except it occurs at the junction. Guess what we're covering next week? We're going to be talking about ventricular rhythms. And guess what you have from the ventricles? You also have a premature ventricular contraction. Okay? Those are most of the time really easy to identify. But basically what we're looking at in here is that this is exactly what it looks like. First of all, it's early, okay? Second of all, we don't have a P wave. Now, that's going to be one of the key things that you're going to be... let me back up here. Okay. You do not have a normal P wave that's going on in this particular process, okay? It is possible that we could have a PJC with a P wave occurring afterwards. I would just about argue with you that that is exactly what you're seeing in this situation right in here. Somebody tell me why I could make a valid argument. I can still be wrong, but I can make an argument for it. But tell me why I think I can make that argument. So we've got an inverted T wave down there. Okay, so that'd be one thing. What else? Good faith. What else? Don't go dead on me now, guys. You got some extra points on this test. The T wave is larger. So we could potentially have a T wave and a P wave together. All right, so that's going to be the two reasons. So Faith said the T wave is inverted. That's a little weird. But if we have an inverted P wave, that may be the reason. And as H said, the T wave is larger than the normal T wave it looks in there. Now, remember, we said that with PACs, you could potentially have a compensatory pause or not. Now, somebody remind me that compensatory pause means if it's there, why is it there? Yeah. Oh, wait a minute. What was that? Okay. Let me take a breath here. Let me get started back up. Same way with PJCs. Same with PVCs when we talk about them next week. Most always you'll have a compensatory pause with a PVC, and we'll talk about why that is. Okay. Now, again, in that regard, you may or may not have a compensatory pause, but you will see that. So our 5-step that we're going to go through here is number 1, what is the rate? Well, guess what? Our rate is the underlying rhythm plus the PJC or Cs that you have in that particular 6-second strip. Again, when you're identifying now on your quiz, your quiz is a multiple choice quiz this week. Okay, so everybody make sure that you're in there working on that. So again, I did not put like an underlying rhythm if the rhythm is a PJC. But again, you're going to have short answers on your exam. So again, make sure that you are calculating that in. And if you want, and when you tell me the name again, like most of y'all did on the PACs, if you say, oh, it's the 3rd and the 7th, and that's exactly what it is, Tacey, you get some extra bonus points, okay? The rhythm will almost always be regular except for the PJC because it's going to be earlier. And if there is a compensatory pause, that's going to throw the rhythm off as well. If you look at your P wave, okay, as it says in there, number 3, number 1, it can be inverted or it can be absent. Okay, now that's a misnomer because you'll have a P wave. You and I just may not be able to see it. It may be swallowed up in the T wave. It may be swallowed up in the QRS. Okay, now let me ask you a question. If it's swallowed up in the QRS of a PJC, would that not make the QRS wider than 0.12 seconds? Why not? You're right. Tell me why you're right. I asked you first.
Disrupt or elongate the conduction of that.
You can rephrase the question, but I've already asked you first. It would not. It would. Oh, well, there's a reason for it not to. What is the reason as to why, if that P wave is embedded in the T wave, that T wave is not going to be wider than normal?
Because the P wave is small enough. It would just get overshadowed.
Remember, your whole atria, or your whole right atria, is about that size right there. Okay? Now, remember, if you're thinking that size right there, and your heart itself is this size, and 75% of your heart is your left ventricle, and plus your right ventricle, definitely, again, a shout out to Morgan and Morgan, size does matter. And in this situation, size doesn't matter. So again, we cannot see a P wave, or it could occur after the QRS, okay? Which is kind of weird the first time that you see it, okay? Now, your PR interval is usually going to be less than 0.12 seconds, okay? If you have a P wave that is not there, obviously, if you can't identify a P wave, you don't have a PR interval. We've already identified that in what 2 rhythms? We've already talked about that in what 2 rhythms? Flutter. Fib and flutter. Very good, gentlemen. Sir.
So, if the P wave is embedded, can the P wave also be embedded in a PAC?
No. Good question. Let's think about this, okay? Dylan says, can the P wave not also be embedded in a PAC? Why do I tell him no?
Because it's an atrial initial start.
So it's initiating up in the atria. It's following the same pathway. The big difference is, or the only difference is, it's occurring early. So you got to have that atrial depolarization, and now it comes on down to the ventricular depolarization. Does that make sense?
Yeah, I was looking at like a strip of a PAC, and like there's one where it happens where it's literally there's in between the QRS complex, there's one wave in front of it. So my interpretation of that was embedded in there.
If you can do a screenshot and send it to me, I'll be happy to look at it. But normally with a PAC, you will see the P wave in, with the exception of there may be one time when you would not see a P wave. When would that be?
The interval's so short.
And we would call that rhythm what? Mm-mm. When our R-to-R intervals get really, really short, what do we call that rhythm? Generic overarching umbrella term. Tachycardia. Say it like you mean it, man. Tachycardia. Yeah. So it's a tachycardia. So when our R-to-R intervals get closer together, we may not see that P wave. In that situation, it is often in the eye of the interpreter. I may look at it and go, no, there's no PAC there. You may look at it and go, yeah, I think there is. If you measure out the R-to-Rs, that one's earlier. We both may be right, or we could both be wrong. The ultimate thing here, ladies and gentlemen, is to make sure that we're not missing life-threatening dysrhythmias for a patient. Okay? So the last one down there is, do all our QRS complexes look alike, and what's the length or the width of it? And it's going to be less than 0.12 seconds. Now, again, it says in there, if no defect in ventricular conduction. We'll learn more in advanced cardiology about ventricular defects that would cause that to still be a PAC, and I mean a PJC, and potentially have some conduction abnormalities, but we'll save that for another class. So as we're going through in here, okay, where is the PJC? Third impulse. Look at this one right here. Let's take a closer look at it and compare it to the others, okay? As we're looking at this one, all right, do you see a P wave? No, on the PJC, do you see a P wave? Braden. You know, here's the thing. If you tell me no, Skylar, I'm going to go, okay, I'm okay with that. Braden, if you tell me, yeah, I think I see a small P wave in there, I'm going to say, I'm okay with that. All right. Again, as we look at this, because look at our P wave right there, and then we come over to this one. Is that our P wave? It could potentially be. Why? Because it could be down on the lower end of the AV junction, right there at not only where I was standing, but if I walked over to the door, one step out, I'm out the door. And that may be what we would see in there. So this is one of those times when we look at it and we go, we'll agree to disagree. It's okay because we could both be right or we could both be wrong. What else do you notice? Now, first of all, if there's no P wave there, there's no PR interval. Braden, what would you estimate if you're calling that a P wave? What would you estimate that the PR interval is? Yeah. I would estimate it to be one small box, which is 0.04 seconds. Much, much shorter than what we would see in here. Now, look at your QRS. What do you find interesting about that QRS? It's almost identical to the other ones, which means, come back to your statement a while ago, it's following the normal conduction pathway. It's following the exact same conduction pathway as these up in here, where we have very obvious atrial depolarization. Do you have a compensatory pause?
Yeah.
Now, when might that and I may have asked you this before, so if I did, we'll see if you were listening. When might that compensatory pause be a problem? Say it again. When the rate is slow. If the rate is already slow, if the underlying rate is already slow, remember, this is the underlying rhythm would be what? No, of this one. Normal sinus rhythm. But again, Dylan, if it were sinus Brady, and now we're getting multiple of these PACs with that compensatory pause afterwards, now our rate may even be slower because of the premature beat that we've got going on in there. Okay. And that's the thing that we're looking at. All right. Does everybody understand why that's a PAC? I'm sorry, PJC. Thank you.
So if there was a P wave in that spot right there, that would be considered a PAC.
It depends on what.
If it was
If it's an upright P wave, that's a PAC. If it's an inverted PAC or inverted PJ, I'm having a stroke today, folks. Thank you. Yes, it would be a PJC. Yes. Now, do you see any more in there? Yeah. Which one?
Yeah.
Now, let me zoom back out. Are those, remember we talked about words called focal. We have multifocal and we have unifocal. What do those words mean? All right. So would you classify those, another opportunity for some bonus points here. Would you classify those as unifocal or multifocal? Why?
Not the P waves that do appear, they regular.
It has nothing to do with the rhythm. It has nothing to do with the rate. It has everything to do with how it looks. So everything on that first one and the second one towards the end, they look almost identical. Okay. So we're pretty sure that it's going to be coming from the same focus or foci. That's focus is multiple, foci is singular. So we would classify this as a unifocal PJC. Okay. Now, if you just identify this as normal sinus rhythm with a PJC, I'm okay with that. All right. Anybody not clear, bless you, anybody not clear on why that's a PJC? Let's go to the opposite end of the extreme now. We've talked about a premature junctional contraction. Let's talk about a junctional escape rhythm. Now, let's think about this for a second. Why would it be named an escape rhythm of any type? Because we can have ventricular escape rhythms as well. What is happening? Let me back up. What is not happening that would cause this to be identified as an escape rhythm? Say it again. Tell me a little bit more. So if we turn this upside down, okay, and we just want to look at this spot right in here. What would we classify this spot as? No, just this space right in here. If we turn this rhythm upside down and we're looking at it, we get this one right here, and then we've got this right here. What would we call that? Say again. Compensatory pause. Yeah, good. Very, very good. Except the compensatory pause is happening on the front end of the QRS. It comes right back to what you said just a second ago, Faith. Something is happening that the SA node or the AV node has not fired. And now the AV node goes, I guess I'm going to have to do something. I got to throw something out there or Bill's going to pass out. So we throw out a junctional impulse. How do we know that it's a junctional impulse? I'm glad you asked. Let's look at the process. Okay, so you look at the rate. Usually your rate is going to be down on the slow end. Remember, with a junctional escape rhythm, you also have an underlying rhythm that you're going to want to look at there as well. Okay, so you're going to go down in there. So we want to look at the rhythm, and it's usually going to be regular except where you have the escape, because now instead of having a compensatory pause on the back end, you've got dead space on the front end, which means that there's no electricity happening. If there's no electricity, there's no mechanical action that's happening either. Okay? A P wave present for that escape. Well, if it's coming from the junction, the answers are the exact same as what we said a little bit ago for the PJC. It could be there and it could be inverted. It could not be there and be in either the T wave or the QRS, or it could potentially be right after the QRS. Same rules apply for your PR interval. If you've got a P wave in front, even if it's inverted, you have a PR interval. Normally it's going to be much, much shorter. If you don't have a P wave in front of the QRS, it's absent, or it's after the QRS, or it's embedded in the T wave. We do not have a PR interval. The other thing that we're going to look at here is that our QRS complexes are going to be the same. Going to be the same. All right? Questions? Yes, ma'am. That would be perfect. Yep, that would be perfect. Yep, you're exactly right. So let's go back and look at this one a little bit longer. Okay, so as you can see in here, we're tacking along. We're moving along. So we got 1, 2, 3, 4, 5, 6, 7. This would be normal sinus rhythm just based off the rhythm or the rate alone. We got to look back and compare, because what we want to do is we want to compare our underlying rhythm, and we want to compare it to the escape beat. We see our P waves, they look normal, they're upright. Every P wave has a QRS, every QRS has a P wave. The PR intervals in this situation are completely normal in all of them. Then we want to look at this thing right in here. Anybody see a P wave there? Yeah, you got a little bitty type of a bump here, but I would tell you got a bump there and you got a bump there. That's probably either hair or the patient's moving. That would just simply be artifacts. So I would tell you we do not have a P wave prior to the to the impulse. Now, what if I told you, and I'm not willing enough to bet the house on it, but what if I told you I think there may be a T wave embedded in that T wave, or a P wave in the T? Why would I say that? Mm-hmm. So as we're looking at this one right here, we look at our T wave, upright and peaked, upright and peaked. Look at this one right here. We've got kind of a plateau over here on this one. Now we do see it over here on this one as well. So it may or may not be. So that's why I'm not willing to bet the house on it of saying that's the T wave and a P wave combined together. But in that situation, we definitely do not see any kind of a P wave. No P wave, no PR interval. What do you notice about the QRS? It's normal. It's completely, totally normal. Okay. And so that is what we would call being our junctional escape rhythm. Basically, it is a safety escape impulse that is in there. Now, remember, simply because you see this on your EKG does not necessarily mean that you've got mechanical action. The only way you can do that is by assessing your patient, watching your monitor, and you would feel that beep, 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 beep. And often that R to R interval right after the escape beat will often be a little bit shorter than your normal R to R intervals. Anybody got any questions? Yes, Dylan.
So the junctional escape rhythm, is it essentially like does it follow the same like guideline of like the sinus block, except there won't be a normal P wave before it?
Yeah, I think that's a good way to put that. Yeah, because in essence, what we've got in here is it. You could make an argument that that looks kind of like sinus block because we only have one impulse that we're missing. Or potentially you could see a sinus arrest with the whole depolarization picking up with a junctional escape beat as well. That's a good way to look at it. Excellent. Anybody else? Hey. So are you talking about right in there? No. Because if that's a P wave, now what are we thinking about? Mm, probably not. And the reason being is that this would not be a junctional, because again, when you have a junctional escape beat, you're either going to have a PR interval that you can't measure, or it's going to be shorter than normal. If that's your P wave right there, How long is your PR interval? It's like 2 hours long. So that's why I would tell you this right here is probably artifact. Again, patient moving, maybe he's got some moisture on their skin, maybe you're monitoring the Sasquatch and you didn't get him shaved off really, really well or whatever. So these are good questions. Anybody else? Okay, it's Monday. We're kind of getting towards the end of the semester.